Good morning, chairpersons and delegates. At the outset, I'd like to thank the organizers for this wonderful opportunity. Thank you for having me here. I would be speaking on comprehensive facial assessment, what constitutes the attractive face. There's a slight delay in between when I click and the projector. So when we embark upon this journey, when the patient comes to us, we basically thinking of the patient as an aesthetic journey. Now the roadmap to that journey has to be correctly defined and safely defined, where natural beauty is the destination that both we and the patient seeks. But there has to be a roadmap to that destination. Now, if I have to reach to one corner of the room, maybe I'll walk straight, some of you will take a curvilinear route, somebody will walk in between the chairs. But it is okay as long as we reach the correct destination. So, when you think of a safe journey, we have to first define the starting point, how the patient appears when they come to you, and the destination, how they end up looking when they're leaving from your office. Now, whether that destination that the patient has in mind and your destination is the same or not will define whether you are successful in your treatment or not. Aesthetic practice is a very subjective practice. What is beautiful to you may not be beautiful to the other person. So it is very important that your destination with the patient matches very well. We are living in a selfie era. We are over-assessing ourselves. We are over-assessing others. When patient comes to us, they already have over-assessed themselves. They're getting over-assessed by others. So there is, on the whole, an over-analysis of the appearance. But the problem is where? The problem is that whenever they are assessing themselves, they are watching themselves in 2D. They're watching themselves in mirrors. They're watching themselves in photographs. It's 2D. It's not 3D. But what you are seeing is a 3D image. You have to translate your vision into the patient's mind. And that is where you will succeed or where you will fail. Because what changes you are doing, what deficiencies you are seeing is in 3D. And what changes they are seeing and what deficiencies they are seeing is in 2D. So this is a very, very important thing. When you are consulting with your patient, it has to be very importantly and very diligently, very subtly pointed out the changes that you would like to make that will create a positive difference in the patient's image. We are scientific people. The patients, they're not like us. We have to simplify and deconstruct. As scientific people, as a scientific approach, we have to simplify things, list them in order, list the corrections, list the faults in order, and then correct them systematically. So basically, our job is to simplify the problem and deconstruct the problem. Now, how do we do that? We do that first by dividing our assessment into a dynamic versus static assessment. So when we are seeing that the dynamic, basically these are expression lines, as has already been pointed out by Dr. Niharika. The static lines are basically the lines in the folds. The dynamic will eventually convert into static. So when we are dealing with static lines, basically we are thinking in our mind about treatment with toxin as well as fillers. Of course, there is some interplay between the two. The static will affect the dynamic will affect the static. So we have to strike a balance. When a face is given to us, we have to know where toxin would affect positively and where voluminizing would affect positively. So this is a very, very important thing to be kept in mind, because many a times patient will walk into your office and say, oh my God, I don't want Botox. Don't do Botox. It's something that is very negative. Most of the patients will say that. But you have to explain it to the patient why you think that toxin will affect the look positively and why they would need fillers. Now, when we're talking about the upper face, basically when we deconstruct, we have to deconstruct into various heads. The first is the forehead and the glabella, where of course we are mostly talking about a toxin-based treatment, a botulinum-based treatment, where it is mostly the dynamic lines that the patient will be concerned about. When we come to the periorbital area, it is a very strong interplay between the dynamic and the static. So here we are talking about the tear troughs, the orbitomalar component, the crow's feet. So basically, a combination treatment with toxin and filler will be required. The nasolabial folds is basically with the filler, but here we have to understand that the treatment will start not at the problem point, but away from the problem point. That is, we have to start around the mid-cheek to correct the nasolabials. There's a paradigm shift in the understanding of nasolabial folds. Earlier, we were actually injecting into the nasolabials to correct them, which led to nowhere. And now we are wiser. We've understood that the treatment will start much above the nasolabial fold. And it is usually, many a times, you will not actually inject in the nasolabial fold to correct it. When you've done the mid-cheek, you will see that the nasolabial fold is automatically corrected and you do not need to inject the nasolabial fold directly. The temple, of course, is mostly the loss of volume, and it has to be filler only. When we talk about the lower face, there's my talk on the lower face also ahead, so I'll just be touching these points. When in the lower face, when we deconstruct, it has to be the nasolabial fold, starting with the nasolabial fold, the perioral, the chin, jowls, jaw, neck, and the decollete area. So this is your deconstructing heads of the problem that the patient can come with. Now, somehow it is just hardwired into our brains that anything that falls within this ratio, which is the 5, which is the golden ratio, we consider it as attractive. It is not only in the human face, it is not only in males and females, it is not only across races, across genders, it is also across anything of beauty in nature, a snail shell. Many times companies in their logos will also use this golden ratio to make their logos attractive. When you analyze the paintings of the Renaissance era, even the modern day paintings, what comes to as attractive bears this golden ratio. And this ratio has been very widely studied across physicists, across mathematicians, across plastic surgeons, dermatologists. So all of us agree that this is the golden ratio that we want to attain in a face when we are treating a face. Now, what are the desirable features? What is an attractive face? The first and foremost desirable feature is definitely symmetry. Anything asymmetrical will be very, very easily pointed out even by a layman. So the first thing that both of us, the patient and the clinician, will desire is symmetry of the face. Oval versus square, again, as already pointed out earlier in the talks, female, the most preferable shape of the face is an oval face and then the heart-shaped face. And a square face is more desirable in the male. Higher cheekbones are desirable in both males and females, although females desire a higher cheekbone than males. If we end up giving the males a very high cheekbone, we will end up feminizing their faces. So we definitely have to give them high cheekbones, but at the same time, we have to remember not to feminize or voluminize the male cheek too much. A chiseled look is something that the patient will come demanding that, I want a chiseled look, make my look chiseled. I don't look good on camera. So chiseled look is across gender. They will want that there should be a chiseled look. A sharp jawline is also something which is considered a very desirable feature. But when we are deconstructing a sharp jawline, we have to differentiate between border and bulk. A bulky face is not an attractive face. A sharp face is an attractive face. So sharpness is given by the border and bulk is given by volume. So here we have to understand the fine difference between bulk and border when we are treating the jawline. A longer chin is more desirable in the female. A wider and longer chin is desirable in the male. Of course, there's always this debate between fuller versus lifted. Patients will always come with photographs of celebrities who are overfilled and they will say that I don't want to end up like this. Doc, don't make me look like this. So we have to understand this difference between filling and lifting. And where that filling will end up being as overfilling, you have to stop short of that. That is a successful treatment. Your consultation with the patient is very, very important. They are not scientific people. They will not come to you with a diagnosis that I'm aging, that I have, periorbital, I have malar fat bags, or I have nasal. So basically, you have to understand what they come to you with. They will come to you with a tired look. They'll say, "Doc, I look tired." Everybody says that I look tired. Everybody is pointing this to me in office. So that means when you're deconstructing that what you have to treat, when a tired face comes to you, when the patient himself or herself is saying that I have a tired look, you have to understand in your mind that it is the upper face that the patient is more bothered about. They say that I look angry. Again, this is the upper face. If a patient comes with an angry look and wants to get that treated and you give them a sharp chin and a sculpted jawline, it is leading to nowhere. So you have to understand that when you are dealing with an angry look, it is an upper face and usually a toxin-based treatment that you are wanting to give to the patient. Usually the patients will notice the lines in the upper part of the face. When they say I have lines, they mean the upper face. When they'll say eye bags or hollowness, it is periorbital. And this is one of the most challenging areas in aesthetic practice. Periorbital has to be a comprehensive treatment. It is almost like treating the full face when you're treating the periorbital area. Now, when they say that, when they just come with a general statement like, I am not as attractive as I was, make me look a little more attractive. You have to take a step back and think that what is it that you can offer that can help you achieve that goal. You have to actually deconstruct and identify the problems, what is making them feel that they are not attractive anymore. So here you have to do a comprehensive assessment of the face. I'm sorry. Again, when they come with folds around the nose, nasolabial folds, it is more or less a comprehensive assessment that you have to do. Now, when they come with sagging skin or loose skin, this might well be a surgical patient. These are patients who will end up being unsatisfied with a minimally invasive procedure. So here you have to actually assess whether your non-invasive procedure, whether your toxins, whether your fillers will do the job to the satisfaction of the patient or not. Or even if you want to enroll these patients in your procedure, then you have to make them understand what result you can achieve. Because at the end of putting 6 fillers in the face and patient is unhappy, it is not a very pleasant situation. So this you have to actually assess whether you have to deal with it surgically or non-surgically. These are the most dangerous patients, I would say, because after doing a lot on their faces, they will still say that I don't see any change. So when you're treating a very, very loose face, it is mostly a surgical patient to me, and I definitely point it out to them that this is what surgery can do, and this is what filler will do. So you have to be very, you have to point out this to your patient before you start. This figure has already been explained. So I'd just like to point out a little point here, that a young face is a face with curvatures, but smooth curvatures. An older face is with shorter curves and not a very smooth curve. So the smoother curves are broken into more smaller curves in an aging face. So if you see the forehead, one smooth curve breaks down into multiple around the periorbital area also, and all along the face. These smooth curves in an aging face will turn into many smooth curves. Now, this is a little experiment that I did when I was preparing my talk. The left half of the face that you see is mine. The right half of the face is of my daughter's. People say that we resemble a lot. And you can see very clearly in this picture that we do. When you see a young face, it is an open face. When you see an aging face, it is a closing in face. When you age, your face will close in. It will lose volume. It will sag. So when you see the brow area, obviously The younger face has a lifted brow. I have already started drooping on the lateral side of my brow. If you see the upper eyelid, this is a very, very subtle point that usually is missed in our assessments. The medial half of the upper eyelid will hollow as you age, and it is virtually present in most of the cases. So this actually, fillers are off-label usage here, and very often when we do blepharoplasties, we end up hollowing our patients more in the upper eyelid. That is why the shift towards slight fat grafting has come into practice now. When you see the nasolabial, I'd like to admit here that when when I took this picture, I already have mid-face fillers done to myself, and the middle cheek that you see is actually a little more hollow than it appears in this, because it has already been corrected by a filler. You can see the nasolabial fold appearing. You can see a very important change, again, many times will be missed when you're dealing with a face, is the lip. The lip is involuting. The margin is involuting. The cupid's bow is getting effaced. The angle of the mouth is drooping. Another thing is the labiomental crease. The chin, although I have a slightly longer chin, I have a full chin, but still when you compare it with the younger face of my daughter, the chin, the labiomental crease is also showing a decline. These are subtle changes that you have not to miss in your younger patients. Many times, patients, in mid-30s, mid-40s are coming to us who are not aged, but they want a refreshed appearance. How do you refresh them? These are the key points. So, if you just actually see in this picture, a youthful C in the periorbital area converts to an aging V. This is an area very, very commonly injected. Other changes have already been pointed out. The same changes, I'm not going to go in detail about this picture, almost the same changes with more static lines already visible on the face. The relevant anatomy has already been dealt much in detail and very well by Dr. Niharika. I'd just like to rush through this. The fat pads, the muscles, the anatomical dissection in the cadavers of the fat pads, the ligaments of the face already been explained. Now, when you alter the expression, you have to see what dramatic changes botulinum can do. It's a wonder drug, provided it is used properly. So this young lady is only 23, and she says, I don't look attractive when I talk. Both my eyebrows raise up, and I want to have that beautiful expression. How do I attain it? This is how to attain a beautiful expression. So she's just had botulinum injected into the middle part of her forehead, and look at the expression. It is such a shift from the previous one. Another thing that I'd like to quickly point out is you have to avoid feminizing your male patients. You have to avoid leaving them as Mr. Spock. And overly arched eyebrows are not a desirable feature. So in male patients, you will have to inject on a little more lateral than in your female patients. Again, the result of a botulinum injection on the crow's feet. Now, this is a patient who just came for a refreshed look. Again, if you see, she's not too aged, but she's obviously tired. Her look is not fresh. And few injections on the mid-face obviously make her look a lot refreshed. And if you can notice, although she's got a good chin, but a little bit of filler on the chin has made such a difference to her look. It has just completed your treatment. So patient will not point out that I want it in my chin, but it is you who have to analyze and see how you can improve your result with just maybe 0.3 or 0.4 ml of filler left on you. Again, the same thing, mid-face fillers. If done well, only mid-face injected in this patient. And look, it's just post-procedure result. These obviously look better in about 15 days' time. This is a short video. I don't think I have the time for it, so I'll just rush through. It's basically explaining mostly the assessment of the upper face and all. Chairpersons, this is, I think, this would take 5 minutes. So if it, I mean, I can skip it if. Ready for demonstration, and we will assess her in toto from the expression lines. I don't think this is going to play as well, huh? So I'll just escape. All right, so I end my talk with this. This is where I work. We started this place about 3 months back. Under one roof, I have all aesthetics, non-invasive lasers and surgeries as well. You're most welcome to visit me. I'm placed in Gurugram. Thank you very much. Thank you for this opportunity.